Here is our roadmap for today. We're going to map the terrain, scout the target, scrub in for the operation itself, and finally navigate the post-op fallout. Let's start with number 1, mapping the terrain. This is all about the anatomy and embryology that dictates every cut we make. Just look at the incredible cause and effect relationship here between the anatomy and our surgical rules. We have to ligate the superior thyroid artery, which branches off the external carotid, extremely close to the gland. Why? Because higher up, the external laryngeal nerve is running right alongside it. But for the inferior thyroid artery, the rule flips entirely. If you cut the main trunk of the inferior artery, you devascularize the parathyroid glands and plunge your patient into hypoparathyroidism. So, for the inferior vessels, we only clip the tiny capsular branches. It's a brilliant example of how structural origin dictates our technique. Now, this brings us to Barry's ligament, which you can basically think of as the ultimate danger zone. This ligament securely anchors the thyroid to the trachea, but it happens to be exactly where the recurrent laryngeal nerve, the RLN, is most vulnerable during a procedure. When you're freeing the gland, this is the spot where you have to be hypervigilant. Shifting gears to embryology for a quick second, let's talk about what happens when thyroid tissue gets left behind during fetal development. A thyroglossal cyst is that classic midline neck swelling that moves when the patient sticks out their tongue. But here's the golden rule. Never ever just drain it. Simple incision and drain it will just leave you with a messy, recurrent fistula. You've got to do the cyst trunk procedure. You take out the cyst, the entire tract, and crucially, the central part of the hyoid bone, because that bone literally develops right around the embryological tract. All right, the terrain is mapped. Let's move on to step 2 and see how we scout our target through clinical exams and diagnostics. Before we even think about ordering a scan, we rely heavily on our hands. These 3 physical exam methods are absolutely vital. You've got Pizzillo's method, pushing the gland forward for better visibility, and Cryle's method, using the thumb to feel for nodules during a swallow. But here is a massive clinical pearl regarding step 2, LaHaye's method. When you're pushing the gland from one side to feel the other, never press both sides of the neck simultaneously. If you do, you're going to compress the carotids, trigger vasovagal syncope, and the patient will literally faint right there in the exam room. Once you've done the exam and suspect an issue, this diagnostic sequence is absolute law. No skipping steps. You always start with a fasting thyroid function test to establish baselines, and TSH is your most sensitive marker here. Only after that do we check the anatomy with a neck ultrasound. And finally, if it's indicated, we sample the actual tissue using FNAC. When you pull up that ultrasound, you aren't just looking at the size of a nodule. These specific red flags dramatically bump up your suspicion of a malignancy and will directly elevate the Thyroid score. If you see a gland that's hypoechoic, speckled with microcalcifications, or has a taller than wider shape, that's highly suspicious. It instantly tells us we need a closer look. But our final diagnostic step does have one major limitation. Because FNA uses a fine needle, it's really just extracting a soup of individual cells, not an intact structural piece of tissue. To officially diagnose a follicular carcinoma, the pathologist has to see basement membrane invasion. You simply cannot see that kind of architectural invasion with just loose cells. So FNA can never actually tell you if a follicular nodule is a benign adenoma or a carcinoma. Sometimes we'll also bring in a nuclear thyroid scan. If you order a technetium or iodine scan, the visual contrast is wild. The healthy gland lights up, but cold nodules essentially go on strike. They take up zero dye. And interestingly, those non-functioning cold nodules carry a massive 20% cancer risk. That's way higher than the hyperactive, overproducing hot nodules, which sit way down at just a 4% risk. Okay, we have our intel. We've mapped it, we've scouted it. Let's walk right into the OR for part 3, the operation. Now, the surgical sequence here is incredibly rigid. We start off in the rose position, neck extended, head elevated 30 degrees. This gives us a beautiful, gravity-assisted, bloodless field, even though it does slightly increase the risk of an air embolism. After making the collar incision exactly 2 finger breadths above the suprasternal notch and raising the flaps, you must identify and ligate the middle thyroid vein first. Always the middle vein first. Only then can you tackle the superior and inferior poles. If you're dealing with a truly massive goiter and just need more exposure, you might have to cut the strap muscles that overlie the thyroid. But if you do this, it is absolutely imperative that you cut them high up. If you cut them low down, you're going to sever the ansa cervicalis nerve, and you'll paralyze those muscles permanently. When it comes to how much of the gland we actually take out, we've got a few options. Subtotal and near-total surgeries, like the Hartley-Dunhill procedure, exist to supposedly save some gland function and protect the nerves. But long-term data shows their complication rates are identical to total removals. So today, surgeons heavily prefer a straightforward hemi or total thyroidectomy. Why? Because if cancer comes back in that tiny little piece of leftover tissue, operating on a recurrent, heavily fibrotic neck is an absolute nightmare. We also have MIVAT, which goes in through the axilla to avoid neck scars entirely, but that's strictly reserved for very small benign nodules or early T1 cancers.
The cuts are closed, but the patient isn't out of the woods yet. Step 4. Identifying and navigating the high-stakes post-operative fallout.
Remember that recurrent laryngeal nerve we were dodging earlier near Barry's ligament? Well, a unilateral nerve injury is unfortunate. It paralyzes one vocal cord, fixing it in a paramedian position, which causes severe hoarseness. But a bilateral injury? No, that is a massive, life-threatening airway emergency. Both cords are completely paralyzed, so the patient has aphonia, meaning they can't speak at all, and because the sensory supply to the airway is wiped out, they are at an immediate critical risk of aspirating fluid right into their lungs. If your patient struggles to breathe after returning to the ward, you gotta run through this exact checklist fast. While a bilateral nerve injury is catastrophic, simple laryngeal edema is actually the most common culprit. But you also have to instantly rule out tracheomalacia after the tube is pulled, late-onset hypoparathyroidism, and other really sinister mechanical causes. And one of those sinister causes is a tension hematoma. Guys, this is a literal ticking time bomb. If a vessel starts bleeding a few hours after surgery, the blood pools under the closed incision and creates this rock-hard swelling that mechanically crushes the trachea. There's zero time to wheel the patient back to the OR for this. The immediate life-saving fix right there on the ward is to aggressively clip open the sutures and evacuate that blood to secure their airway.
Thankfully, not all complications are immediate mechanical emergencies, but this number right here, 1%, is a sobering statistic. That's the incidence rate of permanent hypoparathyroidism. It happens when those tiny, super delicate parathyroid glands suffer irreversible vascular damage during the surgery, usually because someone accidentally ligated the main trunk of the inferior thyroid artery instead of sticking to just the capsular branches. So if the parathyroids do get damaged, the patient's blood calcium levels will plummet 48 to 72 hours later. The very first thing they'll complain about? Numbness right around their mouth. This hypocalcemia triggers extreme neuromuscular hyperexcitability, and you can visibly test for it on the ward. If you tap the facial nerve, you'll see a dramatic facial twitch. That's Chopstick's sign. Or inflate a blood pressure cuff on their arm, and their hand will instantly cramp into a rigid spasm, known as Trousseau's sign, or the obstetrician's hand. Reversing this dangerous hypocalcemia is all about aggressive monitoring. Once you catch those early signs, check the serum calcium. If it's hovering just above 8 milligrams per deciliter, you can usually manage it with oral calcium and vitamin D3. But if they're having major symptoms like those severe spasms, or if their levels dip dangerously below 8, you have to immediately step up and push IV calcium gluconate to stabilize that neural.